So we always talk about our financial disclosures, and none of them are relevant here today. So last January or so, one of my colleagues, who's a neuro-oncologist at Johns Hopkins, kind of threw down the gauntlet. She laid down the challenge. She said, "There's no such thing as hearing preservation in NF2 schwannomatosis surgery." And uh, and I said, "No, wait a minute, that's not quite right. There's no such thing as hearing preservation." And she was fairly strong about that, and so I kind of set out to prove her wrong and went back through our database to look at this, and so we'll talk about whether or not there is such a thing as hearing preservation in NF2 related tumors. I think that one of the things that's changed, in our lifetime, Greg and my lifetime, is that um, we used to always just think about the three traditional treatments for these tumors, either surgery, radiation, or observation. But now medication's used quite often, and yeah, and we, even though we're talking about hearing preservation primarily, I have to say, there's a lot of considerations. It's not just about hearing, which is what we're talking about today. The patients have life-preserving surgery sometimes that has nothing to do with hearing, just to keep the brainstem from getting compressed and having the spinal fluid obstructed and getting out hydrocephalus. So we have to think about that. And I'd have to say that to a large extent, we kind of place the importance of facial nerve really above hearing often. We really try hard to save the facial nerve, but hearing's harder to save. And equilibrium vision, general overall health. The overall quality of life in patients with NF2 is equivalent to patients that have cancer, because even though it's not a malignant disease, the side effects of it are so great that a lot of people say that the quality of life is pretty poor for some of these folks. The trends in NF2 treatment, let's see, jumping around here. Not sure why. But the trends in NF2 treatment have changed, in the late 19, I don't know if I've turned something on that's making it jump, but anyway, the trends in late 1900s were that most people got surgery, or if anything else, radiation. And bevacizumab was introduced in 2009 by Dr. Scott Plotkin here at MGH. And with that, it caused a big shift in terms of the treatment. A lot of people are getting treated with bevacizumab, and the number that are getting surgery has dropped down. And that's because we can temporize a lot of times with bevacizumab treatment. However, even considering that, treatment either with microsurgery or radiation still occurs within 5 years of diagnosis in 40+% of patients. So it's still a pretty surgical disease. When we think about the factors for consideration in surgery, there's a lot of things that we think about. How early did their symptoms come on? If they came on early, it means they have more aggressive disease. What's the tumor size? It seems to me that the larger the tumor, the less likely we are to save the hearing. The location, whether it's located in the fundus of the IAC or it's got a fundal cap of spinal fluid, that's a good thing. If it's compressing the brainstem, not a good thing. Preoperative hearing loss, we have to consider the preoperative hearing in both ears, whether or not that pattern's stable or progressive. Auditory brainstem response, if it's available for intraoperative monitoring, that's a good sign. If they don't even have a delay in wave 5, that's even a better sign. Direct cochlear monitoring I'll talk about in a little bit, but we don't do that very well here, but there are some places that are getting better at doing direct eighth nerve monitoring. The predicted severity of its mutations, a family history, whether or not there's inflammation in the inner ear is seen on a T2 weighted FLAIR image, and whether or not they respond to any of the drugs that are being used currently. So our treatment choices, when we think about small tumors that are located in the internal auditory canal like these, you say, well, it's reasonable to think about trying to take one of those out and potentially saving hearing. I I think that there are not a lot of centers that would do that. A lot of centers say, no, if they've got good hearing, we're just going to watch them. We'll observe these tiny tumors, and over time, the likelihood that observation is going to be continued is not so great. And with larger, intermediate-sized tumors, you may continue to watch them. But with large tumors, surgery really becomes the option of choice. Um, Sorry, got a little hair trigger on this thing today. But radiation is almost never used as a first-line treatment for these because of the potential for malignant transformation, which is very low, 1%. I mean, but of the patients who get malignant transplantation, it's 5 times higher in NF2 patients than it is in sporadic tumors. Wow, this is really jumping all over. So patients with intermediate-sized tumors nowadays were more likely to consider bevacizumab treatment, and about 30 to 40% of them respond with tumor shrinkage and hearing improvement. That's not so much true in children. It's more likely if they're over 18. Somehow pediatric patients don't respond as well to bevacizumab. But there are a few centers around in the United States that do recommend early surgery if the tumors are small and the hearing's good. And if the hearing's preserved in one ear, then you consider taking out the other tumor, because eventually, until we get better treatments, most of these patients are going to need to have some kind of intervention. And I would much rather take out a tumor like the small ones on the left than large ones on the right. Their overall outcome is going to be better. What are the mechanisms of hearing loss in NF2 prior to treatment? I think the common explanation is, well, there's compression of the cochlear nerve by the tumor, but actually that's probably not true. Even in those that have widened the internal auditory canal, it's probably not a pressure phenomenon. That may be something that's more osteolytic that causes the internal auditory canal to widen. Is it vascular compromise? It could be. Direct invasion of the cochlea or the cochlear nerve by the tumor happens. The excretion of ototoxic proteins into the cochlea, blockage of the cochlear aperture, all these things can happen. But one of the things that we've seen is that when you look at the histopathology, this is a patient who donated their temporal bones to us, and they had a small vestibular schwannoma here that was pretty much localized in the internal auditory canal, with the 8th nerve fibers being compressed along the anterior surface of it going up into the cochlea. But we also, when we look at the cochlea, we see cochlear mechanisms for hearing loss too. You can see that, you can see when you take a close-up look at the cochlea that there's loss of hair cell structure here. There's an acidophilic precipitate, some kind of protein that seems to build up in the scala media. They have hydrops. Normally we think of the Reisner's membrane coming along about this angle. And there's some atrophy in the stria in these patients that were looked at by Dr. Quinnell in our place and Dr. Sam Merchant. And there's a correlate in life with this acidophilic precipitate we see in the cochlea, which is this high signal intensity on a pre-contrast flare image. And these pre-contrast flares kind of show what we think are protein in the cochlea. And this corresponds with poorer hearing in the patient's pre-treatment, as demonstrated by Dr. Ashtarigiri and his colleagues at the NIH in 2014. So one of the things that's very interesting is that preoperatively, the tumor size does not always correspond with a hearing loss. And so here, for example, you see a 35-year-old patient with a small intracanalicular lesion. It's kind of out lateral in the internal canal. And in the right ear, the hearing is quite poor with severe hearing loss in the low and mid frequencies. It recovers a little bit, but the speech discrimination score in the right ear is 8%, whereas this 50-year-old woman with an intermediate-sized tumor has, a mild to moderate hearing loss in the left ear, but 100% discrimination. That just seems like it's not fair. Well, we think that, these tumors may excrete something that's ototoxic that would be potentially damaging to the cochlea. This is a young lady who has a very large schwannoma. Her right tumor has been taken out already, but this left one just really shifts her brainstem over, and she still has a patent fourth ventricle, and her hearing is remarkably good. 88% word discrimination. This is her most recent audiogram. We're also nervous. She's starting to get some ataxia. She's starting to get some long track signs. So this tumor will come out this summer later on, but she's held on to her hearing in a remarkable fashion for a tumor this size. There are natural history studies that have been done that look at the relative rate of word discrimination loss and increase in tumor size, and it's kind of asymmetric. This is a study that Scott Plotkin did that involved, I think, 5 institutions. They looked at 200 tumors. The word discrimination score dropped 16% over 3 years, and 79% of the tumors grew over that same period of time. A smaller study just out of Japan, Wakabayashi, looked at 37 tumors. They had a similar decline over 8 years, almost 9 years, of 20% in the word discrimination, and 92% of the tumors grew over that period of time. So the tumors grow faster than the hearing is lost in NF2. And I'm not sure exactly why that is, but it may have to do with factors we haven't quite figured out yet. One of the things that I think is underutilized is an auditory brainstem response test. We don't usually do this unless we're going to the operating room right now, but I think it's helpful, and I'll show you why in a minute, that it may be useful for prognostication about what the tumor is doing to the nerve and how robust the waveforms are going through the cochlear nerve up into the auditory cortex. And a delay in wave 5 from the normal delays can indicate there's an early process going on that may precede a change in the audiogram. We talk about tumor location, and if I had to say, my ideal tumor location, I'd say one that looks kind of like this on a T2 weighted image where there's a nice fundal cap of spinal fluid here. Some people have looked at that and say they don't think it makes a difference, but in my hands, I do think it makes a difference if the tumor's not right up against the cochlea, because the 8th nerve fibers start to splay as they come out into the spiral ganglia out here, and so they have less tensile strength than if there's still one bundle of tumor going out there that you can dissect the tumor off. We also don't like to see the tumor pressed up against the brainstem. If it comes clear out and smashes the brainstem, that's not likely to be a tumor we're going to save the hearing in. It makes sense to say that patients who come to surgery with poor hearing they're more vulnerable to hearing loss. And this this is actually from a study that we did a long time ago. If the patients had what was classified as Class A hearing in the old Gardner-Robinson category, they started out with good hearing, they were more likely to wind up with good hearing. If they had intermediate hearing, they were more likely to lose it. If they started out with poor hearing, that we never saved it. So I think that's kind of a naturally understood. Another thing that I just throw in, even though we're not really talking about radiation too much today, is that these are 4 retrospective studies that went out to 10 years, and you see that the overall word discrimination score has a similar downward slope in all of these 4 studies. I don't consider radiation, even if it's supposed to be done in fractions or cochlear sparing radiation, I don't think that's really hearing preservation procedure. It may be useful, and we do use radiation sometimes in our NF2 patients, but not as a means of hearing preservation. What's the genetic correlation with hearing loss? Well, there are some disagreements about this middle group, but the patients that have mosaicism or have missense mutations that are considered mild, their mean speech discrimination score in 10-year follow-up out of the UK group was 85%, 86%, pretty good. Those that have severe truncated mutations that are in the more severe end, their mean speech discrimination score is 56%. Those were followed over 4 years. So that makes some sense that the patients that have more severe mutation are likely to have worse hearing. Surgical approach selection, we are not trying to save hearing if we're doing a translab. And we consider, is their word discrimination score less than 75%? If it's less than 75%, but still better than 50%, we may be trying to preserve it. That may not be somebody we'd do a translab on. Do they have good hearing in the opposite ear? How big is the tumor? If they're bigger than 2 centimeters, we're not likely to save hearing. Translab may be the best approach for saving the facial nerve. If they have good hearing, then we'll consider suboccipital or middle cranial fossa approach. And typically, the tumors are located in the internal auditory canal for us to do middle fossa. There are some centers, particularly in Asia, where they'll do an extended middle fossa. They'll cut the tentorium and do tumors that stick out into the CP angle through the middle fossa, but I've never done that. I've always used suboccipital if we're trying to save hearing, and the tumor is proceeding out of the internal canal into the cerebellopontine angle. Dr. Basura, have you ever done any extended middle fossa? I know that there are a few people in Japan that like it.
Yeah, we've done a few when I was at Michigan, where there wasn't a big knuckle of tumor into the CP angle. Maybe not like what you're describing, where you had to release the tent there. Just enough retraction where if you had like a centimeter or so, less than a centimeter into the angle beyond the porous, that would be pushing it, I think. Yeah.
One of the things that we saw in our retrospective review of which nerve, often you can't tell which nerve the tumor comes off, but if it's a smaller tumor and you can tell that it's localized to the superior vestibular nerve, our hearing outcomes are better than if they were on the inferior vestibular nerve, which is closer to the cochlear nerve. So if you get a little more separation, our hearing preservation rates were somewhat better. So this would be a good patient for a middle fossa approach. This one, if they still had good hearing, suboccipital, they do still have a little cuff of spinal fluid here. But you could do a translabyrinthine also, especially if the hearing's not so good. It gives you, in my mind, when you're doing a translabyrinthine approach for a tumor like this, you get the nicest view between the facial nerve and the anterior surface of the tumor coming down. When you come in from a suboccipital approach, the facial nerve is usually pressed against the back side of the tumor. And you can still drill the canal, find the facial nerve and so forth, but if it's a facial nerve preservation that's concerning and there's no hearing to save, I'd rather do this translab. What are the intraoperative factors that affect hearing? Well, the nerve origin I just mentioned. Adherence to the cranial nerves in the brainstem, it's kind of subjective, but some tumors are sticky and some tumors peel off. And the ones that are really sticky, adherent to are invading the cochlear nerves are harder of course, to save the hearing. What if you damage the blood supply to the cochlea? That's not helpful. Surgical experience and expertise is something that we don't often quantitate, but I think there is literature to suggest that the number of tumors that a single surgeon does or that an institution does corresponds with better outcomes in terms of facial nerve function and likely in terms of hearing preservation as well. One of the things that's happened in my lifetime, particularly in the last decade or so, is that I find that neurosurgeons and all of us are maybe a little more cautious about how much tumor we resect. Early in my career, we went for near total or complete resection almost all the time. Now, with intermediate-sized tumors or large tumors, we may go in with the idea of doing a partial resection in terms of trying to preserve hearing and also knowing that we could use post-operative radiation in an older patient or that we have bevacizumab that we could use. But my preference is still always to take out as much tumor as possible. But I see that people are being a little less aggressive now. I don't know, is that your impression too, Greg, or is that just my bias?
No, you're absolutely right. It subtotal plays a lot more of a bigger role now, I think. I
Um,
think that's, yeah.
let me
Even in
just,
non-NF2 patients, if we're looking at trying to preserve hearing,
yeah,
and especially facial nerve, that's another issue, but, separate, when you've got a large tumor, maybe somebody that's maybe late middle age, the rationale is like, why would you risk the facial nerve? Just leave a little cuff of tumor, watch it. If it grows, you could radiate residual. So I
exactly.
think that really, that in the interest of like organ, quote unquote, organ preservation, um, that's become much more at the forefront, I think.
Yeah, I agree.
Yeah.
I agree. This
I
direct,
have a question. I have a question. If you're planning to leave a cup of tumor behind, what would be your intraoperative maybe monitor? Are you looking at the ABR, or is it if as you remove tumor, you're getting more stimulation from the facial nerve, then you probably call it quits at that point? What is your turning point to say, okay, maybe we've got enough tumor?
that leads right, that was perfectly timed question. I think that presently, most centers in the United States are holding up if they start to see change in the response of the facial nerve. However, there are systems available other places in the world where they have really pretty good intraoperative monitoring with direct eighth nerve. We do tend to use auditory brainstem response testing. However, the ABR response requires 45 to 60 seconds of collecting these far field potentials. And so when something bad happens, whatever it was happened a minute before the audiologist can tell us about it. We do use our audiologist or electrophysiologist that are neurologists to do our monitoring, but I don't find ABR to be particularly helpful. You can also lose wave 5 on ABR intraoperatively and still have hearing, so you can't just assume that hearing's gone if you do lose the ABR. But the direct cochlear nerve monitoring is something that I really think is useful when it's done in kind of a different mode than we normally talk about for tumor removal. But Dr. Nakatomi, who's a neurosurgeon in Japan, does what he calls a trans cervical. It's not a trans cervical. Yeah, well, it is kind of a transfer because a low approach to get into the tumor and comes up underneath the tumor, puts a little electrical paddle into the fourth ventricle, just like we would do if we were doing an ABR. And then he has direct eighth nerve monitoring through the case, the electrodes out of the way. But as he debulks the tumor, he has continuous, he's got a great big screen at the foot of his table, and he watches these direct eighth nerve potentials. And he looks at the amplitude and the delay and what's happening. And it actually kind of tracks over time in a way that he's able to see when that's starting to change instead of after it's changed like we do with ABR. And by doing that, you can that guides you in terms of when to hold up on your tumor dissection. You can wait a little bit. If it recovers, then you can continue. But I think um, at least for hearing preservation in unilateral sporadic schwannomas, they show an improvement. And there's a group in Denmark who's adopted this also. And they also show an improvement from 50% word recognitions or 50% hearing preservation up to about 75% using this technique. So I like it. It's a little more time consuming to do it this way, but I've been really fighting to try to get the software here so we could use it. And the company that sells it's been really stinky about it. I'm meeting with them this week. It's been 2 years. We bought 10 units, 10 Nihon Koden units to use in our hospital, and they still haven't given us the software to use this direct nerve monitoring. One of the things we have to describe to patients sometimes is why we don't take out all the tumor. And this is, sorry, generally the estimates, if it's gross total, we assume we've gotten almost all the tumor out, near total 90%. Some people say 95, subtotal 50 to 90%, partial less than 50%, and biopsy less than 10%. You'd think we wouldn't go in and just biopsy these tumors, but I have seen people who do that, and I don't really understand why. It doesn't make any sense to me. But facial nerve preservation is certainly an important one, and if we see the amplitude declining, we may hold up because of facial nerve preservation. Hearing preservation, we talked about. If it's stuck on the brainstem, we don't get very aggressive about pulling it off of there. Bleeding can be a problem. We just looked at 50 patients that had been treated with bevacizumab for some period of time and compared them with 50 patients that had NF2 that had not been on bevacizumab. And we think that there is an increase in blood loss in patients that have been on bevacizumab for a while. So that may be a reason why people would stop too. And if you just are going in to decompress the tumor, as Greg mentioned, it's an older patient, a larger tumor, you're thinking about trying to preserve facial nerve function and so forth. Maybe the goal was just to go in and take out 2/3 of the tumor. But there certainly is evidence to say that if you take out less than 80% of the tumor, it's likely to grow back, and so you may wind up doing other treatment. Postoperatively, if hearing is preserved, how long is it preserved? These blue arrows going down are not supposed to be in here. This is a artifact, but unfortunately, the hearing does seem to go down. So if we don't preserve the hearing, what are the other options? Now, hearing aids are certainly a consideration if they still have some residual hearing. Cochlear implants are certainly possible if we've saved the eighth nerve, the cochlear division of the eighth nerve. Sorry. And auditory brain stem implants. We'll talk about that in a second. One other thing that I would just mention in terms of the genetic severity score, I think that these things are all something to consider. And if somebody has a severe phenotype, then, and that they're going to have the tumor out because they have all of these other associated findings, then I think it pushes us a little more towards early surgery in these patients. So as I mentioned at the beginning of the talk, if you have a small tumor, and if the genotype particularly predicts a severe phenotype, taking out the smallest tumor is what I do. Even if they're close to the same size, I'll take out the one I think that I have the best chance of saving the hearing. So sorry. And I quit using my mouse, I guess. We would, like to see a normal preoperative ABR. Don't operate if the course of the tumor is invading the cochlea. That's not going to be helpful. If the hearing's preserved, consider removing the tumor in the remaining ear. Internal auditory canal decompression for larger tumors may alleviate the pressure, although I'm not sure that pressure is an issue. May devascularize the tumors if you're taking off the dural covering of part of it. I'd say that there's a weak body of evidence to suggest that this is helpful, but I have done it on patients, and they've held out for quite a while with their hearing, so it may help, but I don't think that there's strong evidence to show that it does. And partial tumor resection with real-time direct eighth nerve monitoring may be useful. Long-term follow-up's important, and not a lot of centers are doing it yet. Not that we haven't tried over the years, but I think this new technique is an idea that is maybe helpful. There's a recent young man who came in 2017, had this tiny little tumor out in the lateral part of his internal auditory canal. I believe that was a superior vestibular nerve tumor, if I recall. And this tumor is also pretty small, but pretty located out lateral in the fundus. So I think, the chance of saving the hearing and taking out that tumor and taking out all of the vestibular nerve with it is very high. I'd say it's better than 75% chance of saving the hearing there. 4 years later, when his tumor's kind of impacting the fundus and starting to look like the other tumor did 4 years earlier, the hearing preservation rates drop down with that, and complete tumor resection drops down. So, you know, I would have told the parents, and I did tell the parents, we ought to take that one out. If we save the hearing, we'll go after this one. If we don't save the hearing, at least we can save his cochlear nerve for a cochlear implant. But it's hard to talk parents into that. You know, they're, especially when their hearing's good, and all the neuro-oncologists are saying, "Oh no, don't operate yet." But I think it's not an unreasonable thing to talk about anyway. Here you can see on the coronals, small tumor here. You can see two tumors on this side, and here it was, you know, 4 years later. So we went back through our database and we looked at 322 patients with NF2 schwannomatosis in our institution from 1988 to 2024. 191 of those underwent surgical resections. There were 52 of those 191 that had preoperative word recognition scores greater than 50% in the operated ear. Postoperatively, we were able to save the hearing in 23 patients at better than 50%. And actually, 20 of those patients, we were able to save at better than 75%. There were just a few that were kind of intermediate, but the postoperative hearing preservation, when we saved it, was quite good. However, just as a, you know, kind of a reality check, 20 patients out of 322 is 6% of the total. So it's not, you know, my colleague who said there's no such thing as hearing preservation surgery in NF2, she's almost right. I mean, we did save it, but it was not in a great proportion of the patients in some. And the other question is, you know, I think this is a useful graphic, because what we showed to begin with, the word discrimination scores up the left side, the pure tone averages across the bottom. And this is the new Academy standard for, you know, pre and post-operative testing in patients. And you can see that 25 of these patients had excellent word discrimination and excellent pure tone averages. So these are all patients that had good hearing to start with. Postoperatively, our change was like this. We had a group that we saved that had little or no change in their word recognition score. This is change in word recognition score, change in pure tone average here. And we had a group that didn't. And it was kind of interesting to me, because I always told patients it's kind of a spectrum, you know, it's a continuum, but there are only 3 patients who were in that continuum. It was either kind of an all or nothing phenomena. And that surprised me a little bit, but that's actually what we found. When we look at multivariable logistic coefficients for all of these different parameters, tumor size, word recognition, pure tones, percent of tumor removal, wave 5 present to start, tumor up against the brainstem, genetics, the age of onset of tumor, and so forth. When we look at these individually, and we look at the statistics on them, none of them really were strongly associated with hearing preservation. And part of that is just because they had very wide confidence intervals. And there was a lot of times we had missing data points when we go back and do a retrospective analysis. So we looked also at where we combined all of the factors together and tried to look at them in a logistic regression. And there were 3 that kind of popped out as actually having a substantial influence in terms of our ability to save the hearing. One was the normal wave 5. One was their preoperative word recognition score. This was a little weaker because the effect size was almost across the 0 line, but it was somewhat helpful. And then also, if the tumor was touching the brainstem, that was a pretty negative effect in terms of our ability to save hearing compared to no touch of the brainstem. Our statistician looked at all these factors, and you know, he said, "Yeah, you don't have anything that really jumps out that's tremendously helpful." But the thing that he did that was really clever. I got these turned around a little bit. Let me just show you this. He put this into a super learner model, which it takes different AI models and put them together. He put 3 different AI models together, and with putting in these different factors and imputing some data scores, that his accuracy was 88%, which ranged from 85 to 89%. The area under the curve is 89%. And this Yoden threshold is a yes, we saved it, no, we didn't save it, dichotomous kind of a variable. And he had a 97% sensitivity, 83% specificity, which was quite remarkable if you put in all these factors. And so we're trying to validate this with a couple of other centers to look at it to use this same AI tool and see how well it does at predicting our ability to preserve hearing. So the next question is, if you do save the hearing, how long do you save the hearing? And so we plotted the spider plot. We took of those patients we had that we were able to preserve their hearing, how long did that stay? And you can see, I kind of can see 3 groups. I see the group along the top where their word recognition score going out to 20, 25, 30 years was not bad, not bad at all in that group. There's another group kind of here, it's intermediate. You see this slow downward course where still they had good hearing preservation for 10 years, 15 years, but eventually it kind of dropped off. And then there's this group where we saved hearing early on and they dropped off within 5 years. And so you can say, well, of that overall 6%, of the total population, you didn't really score a home run here, but 7 out of 10 patients that had tumors smaller than a centimeter that we operate on, we saved some hearing initially anyway. And then, these are the 3 different the 3 different AI algorithms that he combined: lasso, random forest, and XGBoost. And I don't even know what that means. I'm trying to learn. I'm trying to get him to explain this to me. But each of these different AI algorithms took from the data that was fed into it, and the bottom scale along here is what relative contribution it made to the overall score on each one of these. Then when they were combined, he was able to get that good area under the curve. So what about the cochlear implants and ABIs? We have 48 patients that had auditory brainstem implants and 43 patients. Open set word discrimination, where you could, no lip reading, about 25% of people got some open set speech. The peak mean word recognition score was 28% in this group, and it tailed off to 19% with time. In the auditory brainstem group, there were some patients who had sleepers. They were put in, but they weren't activated because they still had open set speech in the other ear. Of the patients, however, who got no sound perception, that was 18 of them. There's no users in that group, which is not too surprising. Category 1, where there's sound awareness, there are 12 patients who are in that category, and only 3 of them continue to use their ABI. Category 2, where there's sort of perception, there's pattern perception, but no open set. 4 out of 5 used them, 4 didn't. And where the patients got open set speech, 9 out of 9 continued to use them. Interestingly, I'm going to jump ahead for a second here. Our ABI patients are shown in the blue lines on this spider plot with years going along the bottom. Looks like I've cut it off, but basically one of the things that jumped out at me that I hadn't recognized, is that of those patients that are not very good users, a lot of them quit using it. They said, it's not that helpful. But look at these patients in blue. There's a bunch of them where they scored very poorly early on, and then over a period of 5 to 10 years, their scores climbed. Some of them got up to almost 50%. And there's 3 or 4 or 5 patients like that. There are some where they continued to use it out for a long period of time and really got very little in terms of open set speech. But there are a handful where they persisted and continued to use it. And so I'm going to push a little harder for patients who say, oh, it just doesn't sound like anything that's useful. I'll tell them, well, hang in there, keep using it. It may take years, it may take 5 years, it might take 10 years. But the other thing that's kind of sad to see is that even those who did really get up well over time continue to sort of tail off. And so it's not a long-term solution. The right or the red lines here are cochlear implant patients. Some, got really great open set speech, some intermediate, and some poor. And the variation is so huge it becomes hard to predict. So I'm going to jump back here. Just on our cochlear implant patients that had, here we go. So there were 12 patients that we resected and maintained the cochlear nerve, put in a cochlear implant. 5 that didn't have their tumor removed that got stereotactic radiation, and 7 that were just being observed. And our open set mean open set score is 43%, so substantially worse than normal cochlear implant users as expected. But 43% is quite helpful, to people. And this was a comparison of auditory brainstem implants in the literature. There was a systematic review of 33 studies looking at how they did with environmental sound. That's category 1 in our, where they have some recognition, some pattern recognition is category 2, closed set discrimination, and 31% with open set speech discrimination. So I think our data is similar, although I'm not sure their categories were exactly the same as ours. So, one of the things that a lot of my NF2 patients do, especially the younger ones, is they use digital technology to great advantage. So caption apps like the talk to text apps, they really use those quite effectively, and they find that that's more helpful than using their ABI sometimes. And I can't I can't dispute that with them, although I am going to tell them keep using your ABI and use your talk to text app. It'll probably grow over time. Captioned phone calls and captioned eyeglasses are all really coming along and helpful, I think. I tried a pair of these even realities glasses that, last week when I was at the meeting, and it's kind of cool. I mean, the problem with the devices right now is that they have Bluetooth connection to your iPhone or your telephone, and there's a little bit of lag between the speech and the text coming across the screen in front of you. These Xander glasses are pretty ugly, but it's self-contained. These are $5,000, and yet you don't have to have Wi-Fi. Here it helps to be in a Wi-Fi scenario. That you can read. It looks like the text is about maybe a foot in front of your eyes, and you can see the text as it's being spoken. So I think as technology continues to improve, as AI continues to improve, there will be caption eyeglasses will be very helpful for our NF2 patients. A lot of NF2 patients don't have the best of eyesight, so that's not a long-term solution, but it temporizes and helps. So I would summarize by saying there is some hearing preservation in NF2 surgery. However, it's not much. And this AI superlearner model that predicts outcomes, I'm kind of excited about testing this out. It may be something that we can use in unilateral sporadic schwannomas as well. 75% of the patients aren't hearing preservation candidates when we take them to surgery. Right now, we've just gone through, or we're going through the data to say, what happens if we use our predictive model when they first are presenting? What would the outcome likely be based on our model, which seems like it's fairly robust? Michel Calder-Morides in France is going to use our model too and put it against his data and see how it looks. But it's of the 25% presently, we save hearing initially in about 48%, but 70% of those tumors are less than a centimeter. With surgical treatment, long-term preservation is not assured, even when we do save it. bevacizumab has really made it, it's a game changer in terms of aiding in hearing preservation substantially for those patients that have kind of mid-sized tumors, and it's postponed surgery for many patients. And the new intraoperative monitoring, I think, may be useful. We need to get it sort of up and going, but we definitely need better treatment options. I think AI-driven assistive devices will be helpful. Hopefully, drug discovery coming along through AI algorithms will be better than what we've had in the past at getting us to drugs that are more viable. And eventually, we need to give them back the gene that's causing this problem, and especially in younger kids with smaller tumors, I think gene therapy is going to be the best thing for them, because we'll be getting at the root of the problem instead of just hacking at the leaves all the time. So with that, I thank people who've helped us with our funding over the years. This is a couple of my patients that are husband and wife. They just sent me a picture of themselves. Steve was wearing his O Canada shirt, a great big red maple leaf, and he's Canadian. And Steve and Phyllis Lee are just a great couple. And I think that one of the things that I've really enjoyed in my career, maybe the most important award or honor I ever got in my career, was from the NF2 crew, which is a support group for these patients that I spoke to every year when I was in Ohio. And they gave me a little plaque after 10 years of talking to them. And I just love them. And the NF2 patients are such bright, they don't have any cognitive impairment. They're bright people, and they just suffer a lot with this disease. So I might have said this before, but through research, the impossible becomes possible, and then the possible reality. We got to keep working on this stuff. That's it.
Thank you so much.